All right, what's up, everybody? Russell Linville here. Hey, back to teach you guys. And it's really an honor to be back, so I appreciate it. And thank you to Dr. Hefferon and the team for inviting me back for this lecture. This is an advanced interventions, and so we'll be having a complimentary 3-hour lab that will go over a lot of this. We'll do a lot of case studies, and this one should be a lot of fun. It's going to talk about something that I'm very passionate about, which is the throwing athlete. And so, without further ado, let's get into some of the lecture on what you can do to evaluate and come up with a good treatment approach and intervention approach for the overhead athlete. So again, here's my contact info for those who've lost it or don't have it. It's on the syllabus as well. So objectives are going to be to identify components associated with overhead activities in sports, discuss biomechanics of throwing and overhead athletes, assess an overhead athlete, including all the pertinent anatomical and biomechanically correlated areas, and provide appropriate interventions, including manual techniques, exercise interventions, and recommendations for biomechanical changes. These are all different types of overhead athletes. You could argue some of them are overhead athletes, like the top right, the fencer. That was a unique case I had last year of a fencer with the upper extremity issue. But everything else should be pretty spot on. Your overhead lifting athletes, your baseball players, javelin throwers, football, volleyball, tennis, swimming, boxing, and softball. So there's other ones such as handball, your track and field sports, gymnastics, you could argue, is an overhead athlete sport. And if there's any other ones you want to discuss in class, we'll talk about. But for the majority of this class, we'll be talking about baseball players because they're just the most common. There's millions of youth and collegiate baseball players, and it's probably what you'll see the most of because you compare baseball to these other overhead sports. One, there's more participants, and two, there's more repetitive overuse injuries because of the nature of the throw rather than, say, softball, where there's a similar amount of participants. However, the nature of the pitching throw is much different, and the rates of injury are much less. Swimmers are another one you'll see a lot of, but for this lecture, we'll focus on a throwing athlete. So again, these are kind of what I just mentioned, different types of overhead sports: throwing, pulling and pushing sports, racket sports, and striking sports. And you can pause it here and look at this a little more in depth. We can talk about this in class if needed. So what do we do for an overhead athlete with exam and evaluation? Well, it's like any other person that you would evaluate. You want to look at their objective measures such as their range of motion, their strength, motor control, and maybe something different that you do as a video analysis to see what their throwing mechanics are, or their swimming mechanics, or whatever the case may be. Usually these athletes have video of themselves participating, especially if they're trying to become collegiate athletes. So what are the 5 pillars of returning to sport after injury? And this is just a general consensus here, general pyramid. So you have the base of the pyramid, which is phase 1, your pain modulation and tissue healing timelines, and you have those principles nailed down. Your range of motion comes next. Strength follows that. Motor control follows that. Motor control I like to think of as a combination of strength within a range of motion, so you need those other two before you can get to motor control. And then finally, return to sport testing. And so this makes up your pillar, the steps that Rocky runs up, throws his fist in the air. We're back to sport, baby. Let's go. Think of this also, that's why I colored it this way, is like a stoplight. If we flip the stoplight up and down, you got the green at the top, the red at the bottom. This is going to indicate your level of advancement. And so you have your red light and your pain modulation and tissue healing timelines. And then as you get further up the chain, the more advanced your interventions can be, the more stressful they can be. You have the green light, the go-ahead, to push them much harder. But after an injury, we think red light first, green light last, and then, of course, shades of yellow in between. So pain modulation phase, we're going to talk about patient education, manual therapy, joint mobs, modalities, gentle movement, active range, passive range, active assisted range, things like that. We'll go over some things in lab. In the range of motion phase, which is phase 2, you just need to understand that overhead athletes have unique ranges of motion, And these characteristics are on the side of hypermobility in a lot of cases. So in throwers, we would consider total arc differences. We'll get into that on the next slide. And then swimmers, as I mentioned before, is another one you'll see a lot of, is your hypermobility athletes, your high Beighton index individuals. So things to measure, you're going to measure the total arc of motion, which is a combination of internal plus external rotation, measured at 90 degrees of abduction. Two things come from that. One is something called GERD, not gastroesophageal reflux disease. We're talking about glenohumeral internal rotation deficit. Don't get those mixed up. And then also GERG, which is glenohumeral external rotation gain. And so those two might seem weird right now, but we'll make clarity of it. Sometimes those are written as GHIRD or GHERG, but I like, sometimes we see it as GIRD as well. So interchangeable. Cross-body mobility is another thing we'll measure, lat flexibility and horizontal abduction mobility as well as horizontal adduction. So we'll look at both in the horizontal plane here. Let's quickly talk about total arc of motion. There'll be a supplementary article that goes over this principle here. But external rotation plus internal rotation gives you what's called a total arc, or sometimes you'll see it written as TROM, total range of motion. And again, GERD and GERG are spelled out there for you. If you look at the picture on the right, you can see the picture at the bottom left here. This individual has a total of 180 degrees of range of motion, and this is demonstrating their non-dominant, non-throwing arm. If we look at the picture here, baseball players, or overhead athletes in particular, have a bias towards more external rotation at 90 degrees and less internal rotation. So we'll talk about this more in class. We'll dive into what this means, but just understand that a dominant-sided throwing arm, overhead athlete, overhead thrower, is going to be biased more into external rotation on their throwing side. It gives them an advantageous physical capacity to throw a ball, and likewise their internal rotation will suffer as a result of measuring side to side. So what we used to think is that these individuals, these throwing athletes, were missing internal rotation when we compared it to their non-throwing arm. But eventually the research has caught up and the skills of objective measurements have caught up, where we look at now the total arc of motion. We try to compare those two relative to each other rather than individually looking at internal or individually looking at external rotation. And so sometimes this can be confusing and it can make your head spin in doing all these calculations like at the, the roulette table. Is it roulette? You guys help me with that one in that Hangover movie. So let's talk about humeral retrotorsion, because this is the reason why these individuals have a bias towards external rotation. And again, this helps them throw harder, faster, and easier on their anatomy. If we look at this picture here, we're talking about, this can be confusing as well. You guys probably have touched on this in MSK2 with the hip, looking at anteversion, antetorsion, retroversion, etc. Well, the humerus has a certain amount of spin as it's lengthening when you're growing. And so what happens in throwing athletes is there's a bias towards humeral retrotorsion, which allows an individual to get more relative external rotation range of motion. There again, there'll be a supplemental article on this that you guys will need to read. But the player on the left here, when we center their bicipital groove, I'll teach you guys how to do this. We look at their forearm angle, and we compare that to their non-throwing arm. And so the athletes who are throwers will have more neutral or even an externally rotated relative forearm compared to their non-throwing arm or non-throwing athletes. So again, this is something we will dive into in class, but these are pictures that help you kind of visualize this better. This is a case I had, and we'll quickly look at this video of an individual who has an excessive amount of range of motion. I'll teach you guys how to do this range of motion in class. So what I'm doing here is the patient's in supine, their arm supported on a towel, they're in a slight bit of scaption. I'm externally rotating this person's arm all the way passively as far as I can. They have multi-directional instability. This is a swimmer. We were able to get to 160 degrees. It's the most I've ever seen in the clinic. Scared the bejesus out of me. So we have external rotation 160. Need someone to help you here with the measurement, you can get a stabilizing arm. Again, I'll teach you guys how to do this. She had 50 degrees of internal rotation, gives you a total arc of 210. Typically, we see somewhere between the range of 160 and 180. This person was at 210, hypermobile, pretty good swimmer in the area here. How do we measure horizontal adduction range of motion? Well, a lot of these we're going to block the shoulder blade so we can get true glenohumeral range of motion. You can see here, this is one of the godfathers of baseball, PT, named Kevin Wilk. He posts some great stuff on social media. You should follow him as well about overhead athletes, sports rehab in general. But you can see he's blocking the scapula. He's taking the arm across the body, and then we'd measure it from the acromion to get the angle of cross-body adduction or horizontal adduction. This is me in the clinic with an individual baseball player blocking the scapula. Going to look at shoulder flexion range of motion. We similarly do this as the last picture, where someone will come in with a goniometer and measure that range of motion there, of course. And then one thing I like to look at, and don't really measure this, but just try to get an idea of if this position is painful now, is something called horizontal abduction mobility. And you can see this individual is a left-handed baseball pitcher that's been working with me. You look at the angle of someone who's throwing from a top-down view, and you can see this amount of angulation to get into horizontal abduction. And so I like to get someone off the side of the table and just make sure they can get in this position as well. You can do this with swimmers too, who do the butterfly stroke as a way to see if they're painful or not. Again, this should be a review at this point, but hypermobility characteristics in the upper extremity include your carrying angle as well as your excessive internal-external rotation. We'll also look at ways you can do that by reaching behind the back or into external or internal rotation, and of course the Beighton index or the Beighton score. So we'll go over that in class as well. We will do some practical breakouts in lab as well, so this is something you guys can review before class. But we'll look at active range of motion, passive, on the ones that follow here, and we'll talk about how to do these and look at these in terms of an evaluation more specific to an overhead athlete. Again, we'll do also some strength testing, and so what's not included here, but we do a lot of times for upper extremity athletes, is grip testing, grip strength testing, so we'll do that as well. Some of the strength testing we'll go over, and what I do in clinic is use a handheld dynamometer, which is essentially a portable force plate that you hold in your hand, as pictured in this these pictures here. This is from a Byram et al. Study, I believe out of 2008, and these are measurements that I still do because they're very well known in the baseball world on being pretty reliable. So they're looking at supraspinatus strength, seated external rotation strength, and then prone internal rotation strength. You can also do prone external here. And you can do these, if you don't have a handheld dynamometer, you can certainly do these as a graded out of 5 manual muscle test, which we will probably do in class. So again, we'll look at strength assessment as part of a breakout, handheld dynamometer, or we'll look at manual muscle testing or RIMS with the following. There's also something called the Prone T endurance test. And so this is a test where we have the individual lay prone on the table with their arm off the edge of the table. Watch this quick video. They're going to be holding a weight that's 2% of their body weight. And all they do is they lift up to a level that's at the height of their midline of their body. They need to hold for about half a second to a second at the top. And their goal is to get 30 repetitions. And that's one of our return to sport testing conditions there. So let's see here. If we flip over. The other thing we want to look at is scapular assessment. And these are real case studies that I've had. So let's look at this individual scapular assessment. Get the individuals to take their shirts off so we can see their shoulder blades moving. We're looking for signs of weakness, signs of motor control impairment, those sorts of things. So this individual actually was a soccer player with SC joint discomfort from taking a hit to some, in a soccer game. So let's see if we can play this. So I'm doing is resisting external rotation here. You can see that scapula flips up. That's called a flip sign. That's an indication of periscapular weakness. The left side doesn't do it as much. Actually, if we go back, you can see Can hold that pretty well. He doesn't get that hyperangulation. Let's see here. See how he gets that little hyperangulation there of his inferior angle of scapula? Not so much on the left. And if we take him into scaption, we can break his scaption here, and he maybe has a little signs of serratus anterior weakness. He's getting some discomfort there as well, so maybe some pain-inhibited scapular. You can see just how hypermobile the scapulae are. You can touch them together. The kissing scapulae. Very good. Really great kid. Worked really hard. This is an individual who was a soccer goalie. Something about soccer players and overhead sports, I guess. Soccer goalie, and she tweaked her arm diving to block a goal. So what she has here is I think 3 or 4 pound weights. She's just going repeated scaption here, and what I'm trying to get an assessment of is her scapular motor control. And wonder if you guys can pick out what's going on here.
Keep going.
This is at the athletic training room at one of the colleges I covered sports at during residency. So you can see the other athletes in the background. This is her. We give her a motor control drill, which is these are types of interventions I'd like to teach you guys. A motor control drill where we're getting her scapular muscles to work in coordination in concert with each other rather than out. Sometimes it's hard to control. If you don't have proximal stability, it's hard to control distal mobility. And so that drill seems to help her with scapular upward rotation and posterior tipping. So if we move on, this is a youth baseball player, 13 years old. Now it's your guys' job to determine if this is pathological or this is normal for this age group. You can argue probably either, but I'd love to hear your arguments. So you can see eccentric phase, trouble controlling his scapular motion. That individual had little league shoulder. And this is a 19-year-old individual. One thing I'll just have you guys assess is the arm windows. In class, I'll teach you how to do this. If we stop it here, you can see I'm not terribly tied up in posture. I want to see how he controls. You can see the shoulder blades already dumping, right? So I'm not terribly worried about a lower shoulder here or here. He's keeping weights relatively even, so he's good at compensating a little bit. But I'm looking for scapular dumping, essentially, for lack of a better term. One thing you'll notice on him too, gets a big, upper trap activation here and not so much here. So, this is a little nitpicky. Is it perfect assessment? No, but we do see that there's some asymmetries, and we would actually expect to see asymmetries in overhead athletes with scapular motor control testing. We just want to see if we can make it more efficient, and if they're having pain, is their motor control issue secondary to pain, or is the other way around? Do they have tightness or motor control or weakness issues that led to pain eventually? And I think it goes by case basis. So what do you do with this? Because this is an interesting case. This is not a patient of mine, but it was someone sent me this video asking me what to do. This individual literally has, when he elevates his arms, has a nuchal line shift. No idea what happened to this individual. Maybe some neurological condition, if I was to guess, like a bad thoracic outlet or brachial plexus injury, something of that nature. And this would be me trying to figure out what to do. So it's okay to not know. You kind of go through and you try all different interventions until you find something that benefits the patient, that they can buy in on, and that you feel is clinically warranted. So again, we'll break out. We'll do some scapular motor control testing, which will be pretty fun, I think. Here are some different tables I want you guys to fill out before you come to class, because I'll ask you guys about these different things. So common injuries in overhead athletes. I want you guys to think about repetitive overuse injuries in the shoulder and elbow, instability type injuries, trauma, surgical, I want you guys to try to fill out this chart. So throwing sports, we'll get into the phases of throwing, but I want you guys to, I'll put this article in there as well for you guys to read through. This is an article from 1993, really great article on throwing mechanics. It also talks about different sports as well, but two things we'll just mention. I'll play both of these simultaneously. You guys can see the differences in throwing mechanics from individuals. The picture on the left has pretty ideal throwing mechanics, such as the table, the picture at the top. The picture on the bottom right, the video rather, is an individual who's had 2 Tommy John surgeries. His mechanics are much more long, and he throws much faster than the individual on the left. So there's a lot of arguments on what causes arm injuries. Is it mechanical? Is it training? Is it velocity? I think it's pretty much multifactorial. But the person on the bottom left, rarely injured in his career. Greg Maddux. Picture on the bottom right, injured quite a bit. Steven Strasburg. So again, you can pause it here and look at differences in throwing mechanics between different types of throwing sports here. And again, these are some of the things you look for in a basic biomechanical evaluation. We can talk more about this as we go along, but different phases of throwing. You can certainly look this video up on YouTube and pause it at certain time frames. Zach Greinke, pitching mechanics, slow motion. Just look that up, but you'll see these there. So what do we do for exercise interventions? Well, this is what the class is going to be about. You just got to really, in phase 1, keep it simple, stupid. The KISS principle. Manage pain and swelling, get your range of motion normalized, improve strength, improve motor control, and then return to sport. Those are the 5 phases that I think about. So again, we'll fill these tables out. What do you do in phase 1? This would be, if you go back a slide, pain modulation, swelling or fusion management, mobility drills in phase 1, scapular strengthening, rotator cuff strengthening. What do we do for elbow, forearm, and grip work? And then finally, we try to return to throw. Right? When we get through all those phases, phase 5 is return to throwing, which is probably the hardest phase for PTs that have never had experience to overhead sports or baseball before. What are some drills we do? I'll give you this article by George Davies et al. Really great one on plyometric exercise, and has some good overhead athlete, upper extremity plyometrics. So we do pseudo throwing drills to make sure they're ready to start a throwing program. And these are tables from that article, so I'm going to have you guys read through that rather than speak this to you. So several different types of two-hand plyometrics you can have individuals do to prep them for throwing. This is Jake Irvin, who's a professional baseball player at the Washington Nationals farm system at Tommy John. You can do one-handed plyometrics. All these we're using a rebounder or me as someone who's throwing back to them. You guys can pause and re-watch these. These are also available on my YouTube page as well if you want to watch through them. These are all drills that simulate throwing before we ever throw a ball. You can also do things like perturbation training, which just helps with tolerance to force and gets all their periscapular and stabilizing muscle groups firing nicely. We'll try to go through some of these in class. Perturbation training continued. We have the classic, the body blade. We can go in different positions of throwing motions to simulate time frames during the throwing mechanics that they might be working. Good. Again, these simulate different time frames in the throwing motions. You can see by these pictures broken down here. Other sport-specific drills, I threw these in just so you guys can get an idea of kind of the work that I do with these overhead athletes. Video on the left is a hockey player returning to sport. Video in the middle is a defensive back for the Philadelphia Eagles doing a lot of drills here. And then the person on the very right again is Jake doing some figure 8 slams, simulating the throwing pitch. So what do we do with interval throwing programs? We do graded exposure to throwing. This can be calendar based, like we look at distance, reps, and volume, returning throwing, or we could use a radar gun to assess their objective output in terms of velocity, so we can manage their workload a little better. And we could use technology such as these three different systems. Rapsodo, which is a ball tracking system that looks at spin rate, spin efficiency, things like that, kind of a higher level deal. A lot of pro teams and clubs have. And then the Motus sleeve, now known as the Pulse sleeve, is basically an accelerometer you wear on your elbow, rather your forearm, and when you throw, it picks up data that tells you arm speed and some other metrics that helps you objectify a return to throwing program. This is what those look like. So in preparation for class, what do you need to review? You need to review your upper extremity differential diagnosis from MSK1 for the shoulder and the elbow, because we're going to be going over case studies, and it's going to be your job to start to figure out how you do and examine our evaluation and the interventions now that will go into those type things. So I'm going to give you some different cases, and it's your job to differentially diagnose and then treat the patient on our case study. Thank you guys so much. Really appreciate your time, and I look forward to seeing you next week.